Okay, let's get started on the prototypes for pain, fever, and inflammation. So, we do have a class of prototypes that fall under the general term of NSAIDs, non-steroidal anti-inflammatory drugs. And the two drugs that I'll cover in this category are ibuprofen and aspirin. Aspirin is also considered a salicylate, so sometimes you'll hear about the use of salicylates to treat like inflammatory bowel disease. You may also hear aspirin referred to as ASA. It's an old term. It stands for acetyl salicylic acid, which this is just an FYI, not something that you need to memorize. Okay, ibuprofen. So ibuprofen is an analgesic, it's an anti-inflammatory, and it's an antipyretic medication, typically used for mild to moderate pain, treatment of fever, treatment of inflammation. It's sold over the counter and has a fairly safe profile. Its pharmacologic class is that it's an NSAID, and it is a non-selective COX inhibitor. Okay, so it basically inhibits the production of prostaglandins by inhibiting both COX-1 and COX-2. And what I wanted to let you know, and I'm not sure that we discussed this as we were talking about pain, fever, and inflammation, but the prostaglandins that are generated by COX-1 and 2 can be both protective and cause inflammation. So some of the prostaglandins that are protective help with things like providing mucosa for the gastric lining in your stomach. So again, prostaglandins generated by COX-1 and 2, COX-1 is protective and 2 causes the inflammation. Unfortunately, because these are non-selective COX inhibitors, it inhibits both. And so that's why you get this powerful anti-inflammatory, but you also get some serious possible side effects or conditions as a result of using this. And one of those is GI bleeding. So this is due to the inhibition of COX-1, which again is protective. But when we don't have that, we've inhibited it, we may get peptic ulcers, and certainly anyone who has a history of peptic ulcer disease or current peptic ulcer disease should probably avoid these medications. You want to monitor for bleeding because, again, one of the protective things in there is platelet aggregation. In general, our bodies make platelets so that they can stick together and make clots, and those clots can help us not bleed. People who don't make clots very well, they have, usually if you're thinking like a hemophiliac, they have platelets, but they don't have clotting factors. So I like to use a brick and mortar example. Whereas the bricks are platelets, right? Those little funny kind of discs that you see on a blood smear. And then the clotting factors are all of the different factors like factor 8, all those that come together and form fibrin. And fibrin is like the mortar. So we don't want to take people who have either fibrin problems or platelet problems and cause more issues. So you want to be really careful in people who don't have platelets, who already have bleeding issues, okay? So we definitely want to observe for signs or symptoms of GI distress, nausea, vomiting, heartburn, epigastric pain. That would kind of give us a clue that maybe we're starting to have some of those GI problems. You want to monitor hepatic and renal function. Ibuprofen tends to be harder on kidneys than it does on the liver versus Tylenol, which tends to be hard on the liver. So think ibuprofen, kidneys, Tylenol, liver. And then there's a cross sensitivity with aspirin in terms of allergy anaphylaxis. This is really an interesting phenomenon, and I'm not going to go deep and dark into all the pathophysiology, but we know that people who have an aspirin allergy may very well react the same to ibuprofen. And so it really should not, people who have aspirin allergy really should not take ibuprofen. It's very interesting though. Some patients do fine with it. It's just, I guess, a question of, if you're in the hospital and you have a choice between ibuprofen and something else, I would use the something else if they have an allergy to aspirin. Okay, aspirin. Again, ASA, this is this old um, term that we use, or, you can think of like bear. Aspirin is like, it's kind of like cola, right? Like there's Coca-Cola, Pepsi-Cola, RC Cola, there's all kinds of cola. And aspirin's kind of the same way. So there's many, many different brands, but bottom line, aspirin is aspirin. So this is an analgesic, anti-inflammatory, antipyretic. It's an NSAID. It's a salicylate, and it is also a non-selective COX inhibitor. So very similar, actually, very similar profile to ibuprofen in terms of kind of the way that they act in the body. So it makes it easier maybe to kind of learn them if they are bundled together. This inhibits the synthesis of prostaglandins, again, good for mild to moderate pain, treatment of fever, treatment of inflammation, and because it blocks that platelet aggregation, which normally we think of as a bad thing, it could actually be used in a therapeutic way to prevent stroke and heart attack. It's kind of the little positive bonus of one of the side effects. But nursing considerations, we need to remember that it causes GI irritation. And so we want to have our patients take it with food or have it be enteric coated. Use in caution with patients with bleeding disorders, especially patients with chronic alcohol use, because they are more at risk from bleeding disorders as well. And sort of the aspirin combined with chronic alcohol use could really compound that. You want to monitor for signs and symptoms of bleeding. So what are those? How do we know our patient's bleeding? Well, maybe they're bruising. Maybe their gums are bleeding when they brush their teeth. Maybe they notice that their urine is pink. Maybe they notice that they see little blood clots in their urine. Maybe they're seeing dark stools, which could mean that there's blood in those stools. So patients aren't going to tell you, hey, I'm bleeding from aspirin. They're going to tell you, gosh, I'm just bruising everywhere. Or I noticed that I just barely bumped my leg and now I have a big bump there, which would be a little bit of a bleed. You don't want to use this with other drugs that increase risk of bleeding. This is the same really as ibuprofen as well. So you want to be really careful. Warfarin, heparin, clopidogrel, which you guys have not learned about any of these yet, but these are all anticoagulants that are used for people who are at risk for stroke or heart attack. And so no one who is on these medications should be on aspirin or ibuprofen. You want to monitor hepatic and renal function, again, for aspirin. So very similar to ibuprofen. And it may lead to Stevens-Johnson syndrome, which can cause laryngeal edema and anaphylaxis. And I actually have a slide in here about Stevens-Johnson syndrome, so I'll talk a little bit more about that. And probably the biggest take home for you is to not use aspirin in children. In the old days, like when I was a kid, we did not have ibuprofen or acetaminophen. All that we had for fevers was aspirin. And what they found is that when children were given aspirin, especially in the presence of a viral illness, that some of those children developed what's called Reye's syndrome. And Reye's syndrome is an encephalopathy that can be fatal. And so once we figured that out, then sort of the word came down that we don't use aspirin anymore in kids. Now, the fact that I said that means that, of course, there's some exceptions to that. So we'll talk about that later because it is such a potent anti-inflammatory. Sometimes we look at inflammatory conditions in kids like Kawasaki syndrome, and we just say it's worth it. It's worth using aspirin in this scenario because we know Kawasaki's is not a virus, and we know that aspirin's incredibly good at dealing with the inflammation that tends to happen in these kids' hearts. All right, onward. Tylenol, acetaminophen. So this is an analgesic, antipyretic. However, remember, this is not anti-inflammatory. And because it is not anti-inflammatory, it really technically does not fit in the NSAID category because NSAIDs are non-steroidal anti-inflammatory drugs. So you'll hear it thrown in there. It has some commonalities, but in general, it is not anti-inflammatory. You need to know that in terms of, what kind of medication you may give for what kind of condition. It is an analgesic, pharmacologic class. I'm going to look at that again, but analgesic's good enough. And its action is that it is prostaglandin. It inhibits synthesis of prostaglandins. But remember, unlike ibuprofen and aspirin that do that out in the tissues, Tylenol only does it in the brain, which is probably why it's not anti-inflammatory. So it inhibits the synthesis of prostaglandins in the brain, but otherwise its mechanism of action is really unknown. It's used for mild to moderate pain. This is the drug that you will frequently see combined with an opioid. So hydrocodone and Tylenol together. Hydrocodone, acetaminophen together is Vicodin. So you'll see Tylenol as part of another drug. And the way those drugs will be ordered is they'll say X amount of, like 7.5 milligrams of hydrocodone plus 325 milligrams of acetaminophen. And together they have this really wonderful synergistic effect for treating pain. And so you can use less of the opioid and less of the Tylenol, but when you put them together, they just make this amazing combination. It also works well for the treatment of fever and is used pretty much like water in pediatric hospitals for that reason. Nursing considerations. So we know that overall Tylenol's fairly safe. The big, huge thing you have to remember about Tylenol is that it can be hepatotoxic. And so you need to ensure correct dosing. Do not use it in patients with hepatic insufficiency. Okay, their livers have already taken a hit for some reason, or in those who drink more than 3 alcoholic drinks a day, because those folks' livers are working hard to excrete all of the toxins from alcohol, which alcohol is essentially a toxin or a poison to our bodies. So again, no judgment there, just that is a sort of a fact. It doesn't mean that tons of people don't drink alcohol every day and do so relatively safely and enjoy it and are fine. But when it comes to taking acetaminophen and drinking, it's not good. So probably this is the last thing that you want to take if you come home after tying one on, over at Jack and Dan's or wherever. You really probably want to take ibuprofen, or if you're not allergic, you can even take aspirin. Okay. And then here's the other really big kicker is ensure that correct doses are administered, because it's when we exceed the maximum dose per day that we end up having hepatotoxicity. When Tylenol is taken appropriately, it's a very safe drug for the most part. But there is a maximum daily dose for adults. It used to be 4 grams, and the company that makes Tylenol recently changed this to 3 grams a day, which is 3,000 milligrams. 3,000 milligrams, 3 grams, same thing. Okay. Pediatric patients also have a total daily max, but it is totally dependent upon their weight. And so when you do pediatric nursing, you'll learn more about that. So the key thing with Tylenol is really teaching your patient how to take it safely, right? So making sure that they understand the instructions, making sure they understand not to drink while they're taking it, making sure that they don't have any liver issues. This is not one of those drugs where, if one is good, 2 is better. If 1 is good, 2 could cause hepatotoxicity, and your patient could be looking at liver failure. Okay, Stevens-Johnson syndrome. Now, I put this slide at this point in the slideshow because Stevens-Johnson syndrome is a syndrome that can be caused by NSAIDs and Tylenol, as well as seizure drugs, sulfonamides, and gout medications. But I'm telling you because we're learning about NSAIDs and we're learning about acetaminophen, and you need to know that Stevens-Johnson syndrome is a very serious potential adverse effect, really is what it is. So it's very rare, but can be very severe. And I put this little video here for you. It's like 1 minute and it will tell you about it. But if you've ever seen someone with Stevens-Johnson syndrome, you will not forget it. We had a patient that was about 9 and had it. And this little girl had blisters all over her body, eyelids, inside her mouth. She must have had them in her genitourinary tract as well, because when she would urinate, she would cry. When she was trying to poop, she would cry. She definitely had blisters like in her vaginal area. She had them between her toes. I mean, she was just a terrible, terrible mess and so miserable. So that can be a problem, because then if you really begin to have skin issues, sometimes this can progress to something even more serious in terms of skin, where you're just sloughing all of your epidermal layer, and those patients are at risk for an infection and death. So you'll see on like an Advil bottle or a Tylenol bottle, if you read that small print, that there's a warning. Now, they don't really talk about Stevens-Johnson syndrome, but they're describing it here. So this product may cause severe allergic reaction, especially in people who are allergic to aspirin. So remember, I talked about aspirin cross-reactivity and ibuprofen, right? So they're talking about it right here. It says symptoms may include hives, facial swelling, asthma, shock, skin reddening, rash, blisters. And so if you've had any allergic reaction to a pain reliever or fever reducer, so you've had aspirin or you've had a reaction to Tylenol, you really should not take ibuprofen. And it just gives you more warnings here. But I wanted you to see that Stevens-Johnson syndrome is a possibility. So aspirin, ibuprofen, Tylenol. This is a possibility. You should know what it is. You should know that if your patient's on those drugs and begins to experience any of the symptoms described at the beginning here, that you have a problem and that your patient needs help. Morphine. Morphine is an analgesic. It's an opioid agonist. We know that morphine does not work out in the tissues. Morphine, like Tylenol, works in the brain to inhibit pain sensation, but has a very different mechanism of action, right? it binds to the kappa mu receptors in your brain versus Tylenol working to be a COX inhibitor in your brain, a prostaglandin synthesis inhibitor. So morphine's an opioid, you already know that, and it's for moderate to severe pain not relieved by non-opioid medications. I also wanted to tell you that it is really the drug of choice for someone who's suffering from air hunger. And when I talk about air hunger, I'm talking usually about someone who's kind of at end of life, where they're really short of breath, taking deep breaths, maybe feeling a lot of distress from that. Morphine, because it does cause some respiratory sedation, can sort of take the edge off of that air hunger and help a patient feel less air hungry and feel a little more relaxed about their breathing. It's something that you'll learn about if and when you do palliative care or you're in an ICU setting. But I did want to let you know that because sometimes, you may see that someone's getting morphine and maybe they don't have significant pain issues that you can tell from looking at their medical record, but maybe they have air hunger. So that is a possibility. Nursing considerations, you want to monitor for respiratory depression, sedation, urinary retention, nausea, vomiting, and constipation. These are almost a given when you give narcotics. And the more you give and the longer you give them, the more risk you have for all of these things. Now, not everybody has nausea and vomiting. But, a fair number of people do, and they actually need, some kind of anti-nausea medication. Constipation, that's something that we can prevent, right? So if you know that your patient's on morphine, maybe we need to make sure that they're also on a stool softener. A lot of times it's prescribed, but if it's not, maybe we need to advocate for our patient with the provider and say, hey, can I have an order for a stool softener, a PRN stool softener, or can we start a stool softener on this patient every day? They're having a hard time, defecating. So, and then you want to assess, of course, their vital signs, BP, pulse, respiratory rate prior to administration and during administration, because we know that all of these things can be affected by morphine. And then discontinue use of opioids once pain can be managed by non-opioid medications, because there is that potential for addiction or abuse, or at least dependence. So we don't need somebody on opioids, 10, 20 days out from a procedure usually. Even the most, incredible invasive surgeries, patients can often transition over to Tylenol and maybe Motrin, maybe alternating, or other anti-inflammatory drugs instead of morphine. So I used to work with patients who had kids who were having spinal fusions, and that is a big surgery. It's basically an incision from the base of your neck to the bottom of your spine. And they would go in and put in all this hardware, do all kinds of tweaking and pulling and twisting. And those kids are miserable. But usually by day 4 or 5, we are transitioning them off of a morphine PCA. We're putting them on oral medications, maybe an oral opioid for a little bit. But we had some kids that went off and went right to Tylenol, which was incredible. So don't underestimate how well you can do with non-opioid med, especially if you're using more than one with different mechanisms of action. And then last but not least, morphine requires 2 RN sign-off, if medication needs to be wasted or discarded. So let's say I go into the medication room, my patient's ordered for 1 milligram of morphine. Morphine let's say it only comes in a 2 milligram vial. So if I have to waste 1 milligram of morphine, I'm going to need to get another nurse to come in and witness me wasting that morphine and then signing into the Pyxis that, yes, they watched that waste. That's how we keep track of controlled substances like morphine and other narcotics, and it keeps you as a nurse protected from being accused of using it inappropriately. Okay, naloxone, we've talked about this a bit, but this is a reversal agent. It's an antidote for opioids, and it is a CNS opioid receptor antagonist. So this is a receptor blocker, right? It competes with opioids at the receptor site in the brain, and it reverses opioid intoxication or overdose. Now, overdose can lead to respiratory and circulatory problems that even if you reverse the opioid levels in the patient's body, they may have already suffered enough damage from circulatory and respiratory collapse that they are not able to be resuscitated. However, if you have a patient who has just received maybe a little too much morphine or an opioid, or they've responded to, maybe a small dose in a very unexpected way, you can give some of this and reverse those effects. So you want to have the drug available if you're administering opioids, especially like a PCA, patient-controlled analgesia, or a continuous IV administration. In fact, I would never be happy with an order for continuous IV administration without also having an order for naloxone and know that it's in my Pyxis or dispensing cabinet on my unit so that I could get to it quickly if I needed it. Administration of this drug may cause sudden withdrawal symptoms because it's going to reverse the effects of those opioids right away. So make sure that you know what those symptoms are, and I've listed them here for you. Administration may also reveal underlying pain. And so you've given the Narcan, they're now awake and breathing better, but now their pain has returned because they don't have any opioids on board anymore. So now you want to be prepared to administer something for pain, and you don't have to get that worked out before you give the naloxone, because that is priority. Getting them breathing is priority. That's more important than fixing their pain. But you do want to think about that down the road. You don't want to be just so relieved from fixing their respiratory depression that now you've forgotten that they are miserable. Methadone. Methadone is an opioid analgesic. It is a long-acting opioid agonist. And so it's not really that much different than morphine. However, this does work in the brain to desensitize multiple pain receptors. It blocks cravings for opioids and it blocks euphoria. So blocking those cravings and blocking the euphoria allows someone who's dealing with opioid use disorder the opportunity to slowly sort of pull away from the use of opioids, and yet while still getting that physiologic need met. So I hope that makes sense. It's often called like a bridge, a methadone bridge. So you're bridging them from being completely addicted or dependent on the drug to being able to go on to this methadone, which doesn't provide the euphoria and then allows them, through tapering of the methadone, to slowly wean off and give their body the opportunity to sort of lose the craving for the drug. So it oftentimes in an acute care setting like a hospital is used to facilitate opioid withdrawal after an ICU stay. Again, where patients are placed on fentanyl and other opioids for deep, deep sedation while they're also intubated, allowing their bodies time and space to heal. But the problem is that once you wake them up and they take the tube out, you can't just keep giving them high levels of morphine or fentanyl. You need to switch them over to something else with the goal of getting them off of that altogether. So the same monitoring as morphine, exactly the same, because it still is an opioid agonist. So it can still cause respiratory depression. It can still cause sedation. It can still cause constipation. So again, you want to, give as a taper over time. And then the other thing you want to do is you want to watch for withdrawal symptoms, because again, if this is being tapered, maybe the taper is being done too quickly. It's amazing how long it takes to taper people off of these narcotics. It takes a while. And so I remember taking care of a little girl, and she was on a methadone taper. She'd been in the ICU for quite a while. She had a major injury, suffered a major injury. She'd actually fallen out of a window and onto her head. And she was recovering really nicely, but I remember one day she had a lot of these signs. She definitely had vomiting, diarrhea. She also had an infection, so we're trying to sort of sort that all out. But she was sweaty and she was irritable and just not happy. And as soon as we gave, we hypothesized that it was maybe withdrawal. We gave her a little bit more methadone that day, and those symptoms resolved. Okay. So methadone, that's an important drug to know in terms of a means by which we can hopefully switch someone from addiction or dependence over to not using the drug at all. Sumatriptan is our drug of choice for headache, for migraines specifically. It's not going to work well for attention headache. Attention headache is better addressed with like a Tylenol or an ibuprofen. Sorry, acetaminophen. I'm so Tylenol dependent. Acetaminophen or ibuprofen. But this is a great drug for migraines. So it is a vascular headache suppressant. And I don't like that term because it makes it sound like it can keep it from happening. And that's not the case. It really only works once the headache has shown itself. It's a 5-HT agonist. So it works by attaching itself to these serotonin receptors in the muscles that surround the vasculature of the brain. So smooth muscle, right? And allows for vasoconstriction. My apologies, vasoconstriction. It's good for moderate to severe pain. Oops, my bad. This is left over from our last slide. Please cross this out right here. And what you need to say uses is migraine headaches. That's it. That is really its only use. So nursing considerations, it is not preventative, meaning that you can't take it like, maybe that you get migraines around the time of your period. So you decide you're going to take it, the night before you think you're going to start. It's not going to help with that. So it only works once the headache has started. You don't want to use it in patients with history of myocardial infarction or angina. Angina is chest pain that's caused by vasoconstriction or a lack of blood supply to the heart. So this causes vasoconstriction in the head, but it could also cause vasoconstriction in the vessels of the heart. It won't last for very long, but it could last long enough to give somebody chest pain and give them a good scare. So it should not be used. Don't give it the patient is taking ergotamine-based medications. And I think I talked about this in our headache discussion, that the two main things that get used for migraine is these triptans or ergotamine-based medications. And ergotamine-based medications are old, but for some people, they still work. And for some people, they work better than triptans. But you can't use the two together because they have the same mechanism of action. So pick which one you're going to use. But if they've already taken ergotamine-based medications, it's not working. Unfortunately, you can't take sumatriptan. Probably wouldn't work anyway, right? You want to discontinue. Oh my gosh, this is making me crazy. Okay, this slide also, this particular point right here also needs to be taken out. And I am so sorry, you guys, to have this in here. I will fix it on the slides for notes. And these will be gone. And this will be fixed up here. Sumatriptan can cause mild sedative effects. And it's kind of interesting. I don't know if that's because it really is a sedative or if you're just so exhausted after dealing with a migraine and that migraine goes away that your body's just tired and needs a rest, almost like a time to repair. But you'll definitely see people after taking sumatriptan, they may be able to stay at work or whatever if they've taken it at work, but they may be kind of sleepy and kind of tired, drowsy. And then some patients experience what's called a triptan rush. And it doesn't last for very long, maybe 10, 15 minutes. But it happens when those serotonin receptors are activated and the body, does that vasoconstriction of vessels. And so when that happens, patients can get this tingly kind of sensation. Some people will get like a soreness, almost a tenderness of their scalp or their face. I used to take this drug a while back when I still had female hormones going on. I don't have to deal with that anymore, but I would get in the shower after taking sumatriptan. I took Imitrex for probably about 10 years, and I could not hardly tolerate the water from the shower hitting my scalp. Which is kind of strange. My husband would definitely feel this rush. I don't think I ever felt the rush. And then he would be really sore, like just tender to the touch. And that would only last for a little while and then it would go away. Okay. Oh, my apologies for that slide being so messed up, but it'll be fixed. Okay, prednisone. Now, remember, this is our anti-inflammatory, right? So our therapeutic classes, it's anti-inflammatory. It actually is used, again, for cancer treatment because part of how it works as an anti-inflammatory is that it suppresses the immune system. And so that actually works really well in diseases like leukemia. So oftentimes you'll see prednisone as one of the drugs in the regimen that's being used for leukemia patients. But its pharmacologic class is corticosteroids, also known as steroids. Okay. And we're not talking the same kind of steroids that are used for like performance enhancement. That is different. Those are anabolic steroids, different than corticosteroids. Those bulk up muscle and other things. So don't confuse those steroids with corticosteroids. The action is that it decreases inflammation and suppresses the immune system. That's great. Sort of tells the immune system to chill out and relax a little bit, which is great if you have something like any kind of autoimmune disease. We think tons of these conditions that it's used to treat are autoimmune, like eczema, psoriasis, lupus, ulcerative colitis, Crohn's, arthritis, psoriasis, asthma. COPD is not autoimmune, but definitely has an inflammatory component. COPD is almost always due to smoking. But these other ones, so in addition to, dealing with the inflammation, which is great, they also suppress the immune system. So We have to be careful about this. And sometimes these patients are already at risk for an infection, right? If you think of somebody who has like psoriasis, where you have red, broken, blistery, peely skin, that skin is already not being a good barrier for the patient and is compromised, and so therefore more at risk of an infection. So it's, this is one of those drugs. This is probably one of the best drugs I can think of where you're really doing a risk benefit analysis. For some people, steroids are life-saving. They really improve quality of life, and you have to sort of take the bad with the good. So nursing considerations, in short-term use, steroids are tolerated pretty well. You may get some kind of hyper irritability. You might have some transient hyperglycemia, but just for a few days, probably 5-7 days, not a big deal to take steroids. Okay, it's going to really help somebody feel better. Maybe an asthma exacerbation or a flare-up of eczema or something, poison ivy. So that's great. So that's not a problem. But longer-term use is definitely going to cause issues. So we know that prednisone can cause Cushing's syndrome. And Cushing's syndrome is this overabundance of steroids, right? When we give steroids in pill or injection form or creams or whatever, we're giving many, many times more the dose than a patient would get from their own adrenal glands, right? So we know that our own adrenal glands make corticosteroids, but when we're using them in like mega doses. So that's when we see Cushing's syndrome. Do not use it in someone with active infection because, again, they need their immune system to fight that infection. And if they're taking steroids, that ability to mount an immune response is going to be hindered. Prednisone can cause GI distress. Prednisone is a stress hormone, right? It's cortisol or cortisone is something that we put out when we're stressed. We need it. We need that hormone in order to upregulate our hearts and brains and bodies and other things so that we can be prepared to, run from the scary monster. And so that's great, but it can also cause, GI distress, just like stress can cause, peptic ulcers and other things. So if somebody's on prednisone for a long period of time, they need to be on some kind of GI protectant type drug as well. Usually something like a histamine blocker or a proton pump inhibitor. We'll talk about those drugs later, but just know that if you're on prednisone, you probably also need to be on some kind of a GI protective drug. And then I found this online. I've never seen it described this way, but I think it's a really good way to learn the side effects. And these are really the 7 S's. And these are all symptoms of Cushing's syndrome. Okay, so swollen. Prednisone causes you to gain water weight. So you're going to be watching patients' intake and output. You're going to be weighing them. And you're going to be watching for skin changes, right? Because if they're putting on weight and they're doing it rapidly, think of a pregnant woman, they can also get stretch marks in their skin. So, and steroids also makes your skin thin. So something to think about here is, they're going to have this swollen kind of appearance. And what goes with that is this moon face and buffalo hump. It's actually called moon facies, but they're referring to the face and buffalo hump. So moon facies, if you see someone who's on chronic steroids, you will be able to tell because their face is so much bigger and fatter than it's out of proportion with the rest of their body. And, it gives somebody a look that says, I'm really ill. That combined with excessive hair growth, which is something that we see as well, called hirsutism. And so then all that fine hair that you have on your face becomes thicker and darker, and people become, furrier. And so, yeah. And then buffalo hump is the hump that you see. Sometimes you'll see it on the back of people's necks. It's sort of at the base of the neck, top of the spine. And you'll see people of poor posture, but this becomes like a pronounced hump back there, and it's part of fat redistribution. Second S is sepsis. They are prone to infection due to immune suppression. So really watch for fever, signs and symptoms of infection. Things like pus and redness and other things, that may be dampened, right? It may mask those signs and symptoms of infection. So the patient could be getting really sick while they're on these steroids, and you don't know it until all of a sudden they have like a fever of 103. So you just want to be watching, you want to be looking for things that ooze or skin color that doesn't look right or areas of broken skin. And then, of course, fever and vital signs. And just being on the lookout all the time if your patient is on steroids. Sugar, hyperglycemia. This can be so significant. Again, think about it. Corticosteroids are preparing our bodies for fight or flight. Well, what do we need for fight or flight? We need energy. We need to be able to run, right? And so it puts us into this state of hyperglycemia. And so you need to monitor blood glucose. And if that starts inching up and fasting blood glucose is getting higher and higher, this patient may actually need to take insulin while they're on the steroids. So again, something that is sort of like is a really nasty side effect, right, of a drug. But if the drug is keeping you alive or getting you through an exacerbation, then, maybe worth it for a short period of time. Skinny is the next one. So, and skinny has to do with that fat redistribution, where fat may go more toward like the belly, but their arms and legs will be thin. And long-term use, again, can cause osteoporosis, so bones become porous. Sight. Long-term use of steroids causes cataracts, and so you want to monitor vision changes. And then slowly is what you need to do if you're going to take them off the drug or increase the drug, okay? Because again, it's kind of a shock to the system. So for sure, when you're taking them off the drug, you need to slowly taper. Again, these are long-term use steroids. So never abruptly stop unless it's been just 5-7 days. And it's interesting, it used to be that you would taper no matter what, but last few times that I've taken steroids for an asthma exacerbation, I've only been on it for maybe 5 days, and it's just been the same dose every day, and then boom, done. And no problems with that. And then the last one is stress. So if you are getting steroids, remember your own adrenal glands are not going to be putting out any steroids. So if we're going to put a patient under additional stress, like surgery or put them in the ICU, you may actually have to increase their steroids a little bit so that they don't suffer from a lack of ability to respond to that stress. Okay, I hope that helps. Prednisone, by the way, just an FYI, tastes awful. If you ever take it and take it in a pill form, it is super bitter and you need to put it in the back of your tongue. And for little kids who take most of their stuff in liquid form, it is hideous. And it's quite a trick if you can figure out how to get kids to take that stuff without either spitting it all back in your face or vomiting it up. So, all right, guys, I know this was a long lecture, but I hope this helps really give you insight into our prototypes for pain, fever, and inflammation.